Welcome everyone to Mac Med Spa Salon and Medical. We have Dr. Mitchell Bellucci here from Milford Hospital, and he's going to tell us all about osteoporosis, answer questions, and thank you very much.
No problem. I'm very happy to be here today to talk about osteoporosis. I'm not only a speaker, but I'm a client of Mac Med. I've been coming here for years. It's an excellent spa and salon. But today we're going to talk about osteoporosis, and this is a huge problem affecting 1.2 million people annually. There are over 1.2 million osteoporosis-type fractures each year. And with proper prevention and treatment, we can prevent as many as 300,000 hip fractures. So people wonder sometimes why an OBGYN would go into osteoporosis management or treatment. Do you have any idea why a gynecologist might go in and be interested in bones? Go ahead.
It's all connected.
Yeah, all connected, and 80% of the affected people with fractures are women. So that's a big reason. And another reason was when a woman is in her late 40s and early 50s, she generally has a lot of problems. So they're in their office at the right time to get a bone density scan. And once I put that together, I knew that it would be very valuable to my practice to have the ability to evaluate a person's bone density during, let's say, an annual exam or at a different visit specifically for diagnosing osteoporosis. So this is basically a lecture that we're going to give. Next one down. Beautiful. So one of the things that allows us to start studying osteoporosis was getting a definition and being able to accurately measure bone density. And the definition is basically decreased bone mass, which leads to weakened structure and ultimately increased risk of fracture. And measuring bone density, having accurate bone density measurements, and knowing someone has low bone density is a very accurate way to assess the risk of fracture. It's much more accurate than getting a cholesterol scan and seeing if you're at risk for a heart attack. It's about 10 times more accurate. So one of the reasons a gynecologist is also involved in this study is that women come in at the age of 50 for bleeding problems, they can't sleep, they have hot flashes, and this is all related to decreasing estrogen level. And that's our number one hormone for a gynecologist is estrogen, which we use in everything from the birth control pill to estrogen replacement therapy. So basically, we have a disease that's very common in women and is not only diagnosable, it's treatable and preventable to prevent fractures. Let's go to the next slide, see what we have on that one. All right, if you could read this slide, but we will have a copy actually on the video. What it does is it talks about attainment of peak bone density mass. And actually, most women reach peak bone density at about 20 to 25 years old. And then as they get into menopause, we start to see bone loss. So we'll go over the T-score and the Z-score, but what we're talking about is we want to compare bone density to a great skeleton. If your bone density is low at age 60, it's not surprising, but we're not going to benefit by treating you on the basis of comparing you to other 60-year-old women. So we have both a T-score and a Z-score, and we'll talk about those things. And what it is, it's measurements that compare you to a perfectly healthy skeleton. So it shows that when estrogen levels drop, bone density softens. Let's go to the next one. All right, so basically this is going over the issue we talked about, that it is a life-threatening disease, very common. You're talking about 1.2 million fractures annually, billions of dollars spent in healthcare, and 1 in 4 women over the age of 50 will get a fracture. This could be a spine fracture, where she just has pain here, a devastating hip fracture, which has a 20% associated mortality if you're over 70, or it could be the Colles fracture, where you fall on your wrist and snap the distal forearm. So it's a very common problem. I actually went to Milford Hospital at one point, and I had, let's see, Paul Donna, a finance person, look at the diagnosis on the year, admitting diagnosis, and look at the incidence. And this was in 1997. There were 188 hip fractures, that's inpatient and outpatient, there were 100 wrist fractures, 30 diagnosed vertebral fractures, and if you look at the other diagnoses to give you an idea, there were 21 breast cancers and only 9 uterine cancers. So this shows a huge difference. This is a very common problem. Let's see what we have on the next slide. It does affect men. That's the only good about this. And it generally, men are more protected because of the stronger skeleton in a man. He's carrying around a lot more mass. And bone mass, body mass definitely strengthens bones. That's why if I have a woman who's 240 pounds, I'll say it's a little less likely for you to have osteoporosis, but you still check. And in those women, I would say, well, there's one of the reasons it's okay to have a little extra weight on you. And it's pretty popular if you're presented like that. Let's go to the next slide. I didn't point to you. Fracture risk increases within a year. If you sustain one fracture, let's say you have a Colles fracture of your wrist, you definitely have increased risk of fracture in the coming year. So it's a systemic disease. It's affecting the whole body. I was actually talking to a hygienist who was here, and people will very often have dental problems, and it can be a sign of weakening bones in their hip and their spine as well, because the mandible is very thin. And I've actually talked to dentists on this issue and asked them if they have ever asked for a woman to have a bone density scan because she was losing teeth. All right, let's go to the next slide. We'll skip through that one. All right, so we're going to talk about diagnosis. And the World Health Association helped us a lot by coming up with quantifying bone loss in order to decide when to treat people. And we use what's called the T-score. And I'm not even going to talk about the Z-score because it's not necessary. But what the T-score does is it compares you to the perfect skeleton. And if you're between 0 and 1, -1, and 0 and +1, you're within the range of normal. Once you get down to -1.5, which is 1.5 standard deviations below the normal, you're developing osteopenia. Osteopenia meaning some degree of loss, usually about 10 to 15%. Once your T-score gets to -2.5, you're at the level of osteoporosis, and you should definitely be treated more aggressively. We can talk about treatment options, but it was having scoring like this and measurable bone densities that allowed us to study drugs to treat osteoporosis. So let's go to the next slide. Oh, forget it, I don't use that. This is everybody wants to have a simple way to pick and choose diagnosis, and they came up with a FRAX test, and you put in age and weight and T-score, and it tells you if you could treat. I hate things like that. I love to discuss with my patient how they feel about their bone density, see if it's worth the risk and benefit and cost, and then discuss their feelings on it. Because you could have someone who you really think needs to be treated, and if they don't want to be treated, they're not going to comply with therapy. Whereas I have patients who I know are very worried about osteoporosis because their mother had a very severe case, and they may be a little less than what I would be told to treat, but I would treat them earlier, or at least try to partially treat them so that they feel they're doing something to prevent a disease which normally progresses. So I'm not a big fan of that. Go to the next one. Who should be treated? Okay, basically people who have osteopenia, meaning they've lost about 10 to 15%, they have a T-score of -1.5. These people can sometimes be treated just with exercise, making sure they have adequate calcium and vitamin D, and that's 1,000 milligrams of calcium, 600 vitamin D a day. You can test blood levels of those things, but if they have the low bone density, really, I've sent people to physical therapy to work on exercises specifically for the hip or the spine. And let me ask a question. Do you think that swimming is a good exercise for osteoporosis? No. Nice try, though. Actually, it's not weight bearing. That's one of the beauties of swimming, is that it's easier on your joints and everything. But it's not good for osteoporosis. Going to the gym and doing weightlifting is a much more effective thing, or walking with weights. But we will give you a prize anyhow. Hold on one second. That is specific for osteoporosis treatment in there. In that bag, in that bag. All right. All righty. So let's see. Another thing I would like to talk about more about osteoporosis. When you think about a bone or bones in general, I mean, when you're growing and your kid's growing, sure, bones are neat, they're getting taller. Or if you break a bone, you're really concerned about your bone. But you don't think about much of them after the age of 25. And the bone is actually a very active, growing, and remodeling organ. There are what are called osteoclasts, which actually break down bone, and then there's osteoblasts, which build bone. And these are cells within the bone, within the matrix of the bone, so that even though you're not thinking about it, there is constant turnover of bone every day of your life. And it's sort of the calcium reserve of your body and a lot of other minerals. So when the body needs more minerals, like when you fracture yourself, it builds bone at that fracture. The problem is, as you get older, if you're a woman, the drop in estrogen leads to increases in osteoclast activity. And you don't build as much, and you're destroying more bone. So that's why we can see in women within 2 years of menopause as much as a 10%, 15% loss in bone. And they do nothing differently. So estrogen replacement therapy, which was the first therapy we had to prevent and treat osteoporosis, might be recommended to you if you have a T-score of minus 1.2 and you have a family history, and let's say you have bad hot flashes or vaginal problems with intercourse. Being on estrogen can help all 4 problems. Now, people always worry about other side effects of estrogen, but we're finding that it's safer and safer, particularly if you started early in menopause. So estrogen therapy is sort of the first line, other than vitamins and calcium and exercise. And you would use that with probably mild to moderate osteopenia. Let's go down another slide. So our goals really in treating osteoporosis, it's not necessarily to get a better number on your bone density scan 2 years later. It's so we decrease your risk of fracture. And studies have shown that for every decrease in like a 1 T-score, you have twice as many fractures. So if we can build you back up, we can dramatically decrease the incidence of bone fracture. In patients who have been followed, we're looking at a group that was not treated and was treated, we see a 30 to 40% decrease in fractures in those patients. So it's significant. All right, secondary goal, of course, is taking care of pain, deformity, and physical function. Let's go next slide. All right, so these are treatment strategies. And on this, you could put the slide on directly if you have that one that we photographed earlier. We have non-pharmacological treatment, like we said, calcium, exercise, vitamin D. And pharmacological strategies is basically about 3 or 4. One is, like I said, estrogen replacement therapy. And the most common is bisphosphonate therapy, which is a pill that binds to the matrix of the bone, and it actually inhibits the osteoclasts, so that what happens is when they absorb this medicine, they don't destroy as much bone, so you get more building. And the most common, let's go down one click. So we're talking about bisphosphonate therapy here. Yep. All right, so this is telling you what I just said, that it binds to the bone mineral, it's being taken up by the osteoclasts, and then it inhibits them. And in a lot of therapies, there's always this sort of negative feedback. You get something to grow by inhibiting the decreased growth. There are basically several bisphosphonates, and when we first started treating people with bisphosphonate therapy, which was about 15 years ago, we had daily therapy. Then it improved to once-a-week therapy, and we even had once-a-month therapy. And what famous actress was associated with the monthly therapy. Very good. So the advertising marketing was very well done. Hold on, one other gift for the crowd. No problem. The Flying Nun. Because once she was flying and broke her hip, and that's how the whole thing started. She was for Boniva, which was a once a month therapy. And in order to take... Yes, Blythe is new. She's, let me think. Yeah, she is, I believe, with the newer drug, Prolia. I believe we have a picture of her. Hold on. There we go. We have Blythe right here. And next year I'm going to be on one of the pills. It's going to be fun. Is it? All right, there's a kind of a conference going on right now. All right, so those are the bisphosphonates. And the problem with the bisphosphonates is we've been looking at the data. They definitely work. They decrease the incidence of fracture, but there are some side effects and some things about the drug that make it a little bit of a pain. With Fosamax, you have to take the medication first thing in the morning, once a week, drink it with a glass of water, and you can't lay down or eat anything for about 45 minutes. And that's to allow this to be absorbed. And it's a very poorly absorbed drug. 95% of it is not absorbed. So you have to do everything in your power to let that little bit be absorbed. And if you have calcium or a glass of coffee, you could almost absorb nothing. And then you have failed therapy, because if they do that every other time, then they're not getting the required dosages. Now, they have come up with a new drug called Atelvia, and this drug you can take with food. It's also once a week. It's a bisphosphonate, but it's absorbed in the small intestine. And it seems to be very similar in effectiveness. And I think if you had both these drugs come out at the same time and you had to decide once a week whether you wanted your coffee and bagel or you want to wait an hour, most people would have taken the Atelvia. But it's, it's something that you have to work with your physician, because sometimes you have to fail therapy with Fosamax to be on another drug. That's always any new drug. That's how the pharmacies and your insurance companies see if it's worth paying for the new drug. There are other non-bisphosphonate therapies. One is, let's see if we have another slide. We'll get out of the bisphosphonates here. Treatment. So this talks about the different dosage. Go down again. There was available an IV bisphosphonate therapy that you could get every 3 months and had less side effects. The bad adverse events you can get with the bisphosphonates are GI bleeding. It can cause esophagitis, an ulcer, or sometimes a very serious bleed. In general, we don't see this in young patients. These are mostly nursing home patients in which they kind of line them up on Sunday, kind of try to keep them all up there, and, somehow somebody has a bad side effect. Recently, we've been seeing some problems sometimes with the jaw, with teeth, from the bisphosphonate, and we think that it's probably prudent to only treat for about 5 to 7 years with bisphosphonates. So what we're seeing now is a lot of other therapies coming out, because you still have this subset of patients that you've been treating for 5 to 7 years or 10 years, and it worked, and they didn't fracture, but now they're saying you have to stop it. And we're not going to have the data on those patients for another 10 years, so what do? They have found out, though, that with bisphosphonates, if you look at people who have been treated, they have less fractures than people with the same T-score for at least 2 years. So there is some retained benefit of the bisphosphonate, because it is a very long-acting drug. We'll talk about some other therapies as well. All right, other options. One is Avista. Avista is a selective estrogen receptor modifier, which means it's like tamoxifen. It has some of the effects of estrogen and some not. Women get hot flashes when they're on Avista, but if they're on estrogen, they don't get hot flashes. It actually helps their hot flashes. They get bleeding when they're on Premarin. If you're on Avista, you don't get bleeding. And it turns out that both Avista and Premarin are very much protective of your bone density. They're not going to grow bone as well as a bisphosphonate or more aggressive therapy, but they will maintain your bone density. And in the long run, if you were, what I'll do with a patient of mine who is, I'm on the fence to possibly treat with estrogen, I'll do a bone density scan. And if she comes back with a T-score of -2, I'd say, let's trying the estrogen. It's also going to make you feel better, sleep better, and we'll just have to watch, with ultrasound sometimes the uterine lining. Sometimes we have to do an endometrial biopsy if there's abnormal bleeding. But estrogen replacement therapy certainly is very beneficial for osteoporosis, or osteopenia, we'll say. All right, the other therapies, I'm not going to go into too much. One is a once-a-year infusion of PTH that's reclassed, and I'm sure it's probably thousands of dollars for that therapy. And you basically have probably had to fail bisphosphonate therapy and fracture to really qualify for that. When I have complicated patients like that, I'll generally refer to a rheumatologist and let them help the patient and decide whether she needs very aggressive therapy. Another one let's go down another one here. Keep going, that's just them fighting amongst themselves. Who's the best bisphosphonate? I'd go again. Risk reduction. Definitely this shows that all these products, when matched against calcium, vitamin D, and exercise, plus or minus Fosamax or Actonel or Boniva, there's a definite reduction in fractures, and that's the endpoint that we're looking for. When I had my bone density in the office, which I had for about 15 years, I came out with a Women's Healthcare Quarterly, which I eventually changed to Bone Healthcare Quarterly, and I was basically giving information to primary care docs, nurse practitioners about who to scan, about new therapies, and it actually was very fun to do. And it's amazing when I pull out a 10-year-old version. I did this for about almost 10 years. It's amazing how much has changed. But definitely these drugs work. I'd say it's probably one of the more common prescriptions in women over the age of 55. All right, let's go again. It says here, this is risedronate, which I believe is Actonel, and it shows that these, or Actonel, I think, and the Atelvia, which shows that the benefits in vertebral fracture risk are sustained over 5 years after you stop the drug. So that's pretty interesting. Let's try another one. This talks about the problems with bisphosphonates, that it's poorly absorbed, also has a very long half-life, so we generally don't use it in younger women who might get pregnant. There definitely are adverse reactions, as we said, GI bleeding. There have been some atypical fractures of the leg, but they seem to be very common, and occasionally people have aseptic necrosis of the jaw, but I've yet to see a case, and I've talked to dentists, and it's extremely rare. And I will generally, if someone has a complicated medical background, I'll send them to their dentist when they're having therapy just to get a good look at their mouth. Let's go down another one. I think that's adverse events. Nope. Keep going. Let's go down another one. Poor compliance. That's exactly why Atelvia was made, because when people have to change their lifestyle to take a drug, it's more likely they're not going to change their lifestyle. So if you have to wait 45 minutes and you got to get up at 7 and take a shower and your coffee's sitting there and you're getting hungry, you're likely to fail the therapy. And since it's absorbed so poorly, you're not going to get the benefit out of that drug. With Atelvia, it is coated so that it's absorbed in the small intestine, and that was a very smart move on the basis of that drug company realizing that compliance was not as high as we thought. Let's go to the next slide. Let's keep going on that one. That's exactly what we're talking about, so let's go a little further. Let's just leave it right there. So what I'd like to do, let's see, also talk about, one thing we didn't talk about, how common these fractures are, particularly hip fractures, and it's a life-altering event for many people, particularly men. My father actually broke his hip when he was 69, and it changed the way he thought about his life. And he was in rehab for a while, and when he came home, he had to modify the house, and he was fortunate to live another 4 years, but it definitely changed his life. And in older patients in their 70s and 80s, it's very often the event that takes the person out of the house and into a nursing home. So this is a significant injury amongst the elderly. And we had a picture I gave you out. This kind of shows the progression of osteoporosis. This looks like Japanese, Asian women who are actually at the same risk as Americans and Northern Europeans. You can see the woman slowly developing kyphoses and just crippling kind of fractures of the spine, causing her to bend forward. It can cause pulmonary lung problems, decreased breathing capacity. So it's a significant thing. And in the old days, we pretty much just watched it develop, and there wasn't anything you could do about it. And that's doctors like myself and other doctors who are trying to be ahead of this disease are trying to see if our patients 20 years from now are going to look a lot better. I've got at least several dozen patients, about 5 minutes or so, several dozen patients that have been on estrogen, then bisphosphonates, then Prolia or Avista, and I have not seen a fracture in my practice, which is very fortunate. That's what we're going to hope, is that we can, in the long term, improve these people's lives. And I have 2 cases I'm going to go over, and they're very interesting. They're in your little handout. I had it on a slide that I was going to show, but we didn't want to have the slide projector and the computer at the same time. So this particular one is actually, would you hand me the one right next to you? Women's Healthcare Quarterly. Did I have it on the back of that one? 1 second. Yep, these are the bone scans, okay? So the first one is an interesting patient. Hold on. At the time this lady was scanned, she was 55 years old. She was the model patient. She didn't drink, she didn't smoke, and both alcohol and smoking decreased bone density. She exercised, she played golf. Unfortunately, she was white, Northern European. Her mother had osteoporosis, and she only weighed 108 pounds. She's about 5 foot tall. So she was put on estrogen therapy right when she went in menopause. So this person took calcium and vitamin D. She did everything right. So you might say, well, why did you do a scan on her? You know, she's on estrogen. She's doing everything right. So we scanned her, and this was the first scan she had, and you could already see the curvature of her spine. Sorry. And those are from lateral fractures, fractures on the right part of her vertebral column. Her T-score is -3. That's osteoporosis with fracture. That's severe osteoporosis at 55 years old. So this woman has been on bisphosphonates, has got about a 10% increase. She continued to lose at her hip. So she was actually put on Avista as well. And now she is getting PTH, reclass, once a year. But she's an incredibly interesting patient in that she did everything right except she didn't pick her parents. Very important. If you could pick your parents, it's a big advantage for you in the long run. So genetics are really key. Now the next patient is a very interesting woman. And when you look at her scan, you're going to say, she's 37 years old, and you did a bone density scan, which is exactly what the orthopedist said to me. And I said, well, when she was pregnant, which was in May of 1995, she was walking her dog and she avulsed her patella tendon off her knee. It's a very serious fracture. Of course, she just fell over the dog, and the orthopod had a hard time figuring out what he was going to use as a graft, and he actually used coral, which was very interesting. It was a new thing they were doing in orthopedics. So she had her knee fixed, was in crutches throughout her pregnancy, and then 6 months later, she fell again and broke her wrist. And I said, you know, I know you're kind of a klutz, but I think it wouldn't be a bad idea to take a look at your bone density. So we did, and this is her scan at 37 years old. And at her spine, her T-score was minus 1.7. So at 37 years old, she'd already lost 17% of her peak bone density at the spine. That's a lot. And at her hip, and she was an active, woman, 118 pounds, and her hip, do me a favor, fold that, thank you, my dear. And her hip came back with a T-score of minus 2.3. Interestingly, she was put on Fosamax. She's now about 53. She's not fractured ever again. But interestingly, she developed atherosclerotic heart disease at the age of 49. So her body, for some reason, is about 10 to 20 years ahead of itself. But she's actually a pharmacist, and she's right on top of everything. But if she could have picked parents that had better bone density and better cholesterol profiles, she would have been a lot better off. All right, so let's do this. We'll wrap it up with any questions, and everybody has to ask a question since we have a very large audience. We're going to start with you because you had a good question before.
The difference in the machines?
She asked, your first name?
Jill.
Jill. Jill actually had her first bone density scan, and she said if she has to have another one, can she go to a different machine? Basically, that's one of the problems, that there's about 3 manufacturers, Lunar, Hologic, and I scanned you one day on my Lunar scan, and then the next day, even with the same technician, scan you on a Hologic, there can be almost as 5 to 7% difference. So it's best if you go back to the same place and the same machine and the same tech. Because when they set you up, we always do 2 areas. We do the vertebral column and the hip. A lot of people are now including the wrist, although the wrist is not half as predictive as the other 2 sites. But the technician has to go, we measure L1 through L4, and she's got to get you on that table and make sure she does the right vertebrae, and then take your hip shot and put you at a little bit of an angle to see the hip. The great thing about this test is you don't have to get undressed. You're basically laying on a table, and it's done in about 25 minutes. And then the machine takes your data, feeds it into a computer, and compares you to 1,000 patients of the same age, same color and weight, and it gives us a very precise idea of how good or bad your bone density is. So that's a very good question. Do you have any questions?
No, I think pretty well wrapped it up.
And for my key player here, any questions at all? You have to have one. Come on.
Yes, I could think of one. So I had a hip replacement 4 years ago when I was 40
Something.
or something.
Okay. Hip replacement.
So does that increase my chances for any type of, osteoporosis earlier?
It depends. And certainly you're a candidate for a bone density test. Most people at your age group had arthritis of that hip before. Arthritis is not osteoporosis.
There's no relation.
There can be relationships because degenerative arthritis is more likely if you have osteopenia. So the bottom line is, I try not to make up, am I up at risk? Let's find out what your bone density is. It's that simple. In other words, if it's normal, then all you got to worry about is maybe getting a knee in about 5 years. If it's abnormal, then maybe you want to start treating yourself aggressively with a bisphosphonate. Or if you're getting into that hot flashes era and you don't have breast cancer in the family, maybe you want to go on estrogen replacement therapy. If you had breast cancer in your family, maybe you want to go on Evista, which will decrease your risk of breast cancer by 50%. That's a CERM. So in other words, it's just data, and then we individualize and see what your particular risk is. You had a hip replacement. Is it related? Probably not. But if we take 50 people with hip replacements and compare them to 50 people without hip replacements, I'm sure there's more people with osteopenia in the hip replacement group. Question is, it's just not simple black and white, it's genetics and what you've done to your hip for the last 40 years. If you were born with congenital hip dysplasia as a kid, it certainly increases your risk of a hip fracture, and it may be totally genetic. All right. Another question, very good.
They recommended me age 50 to have one. Is that an average age now that they're doing it?
You had one scan already.
Yeah.
A year ago?
No, just a few months ago.
A few months ago. It depends on what your numbers were. Did they implement any therapy?
Normal.
Okay. If you were normal at an average age of menopause, let's say, I would not do it a year later, because it's going to be at most 5% less. So if you were deciding whether to take estrogen, I might do it in a year, but I still probably would wait 2 years. Every year is probably too frequent. But in the initial phases of doing bone densities, we were all trying to watch every patient, and we were almost impatient. We wanted to see the results of the medications. Now we know probably a year and a half, 2 years is more appropriate, and that's probably what I would do. But if you had normal bone density and you weren't going to take any estrogen and you weren't going to take bisphosphonates, I might wait 3 years. All depends. You just definitely take your calcium and vitamin D, though. And did they check a vitamin D level?
I take vitamin D every day because I was low.
You had a low vitamin D, yeah.
So I take one every day.
I'd say about 70% of the, Caucasian, North European type, English, Irish people are vitamin D deficient. It's incredibly high. I mean, once a week I see a normal vitamin D, and it's shocking. All right, so as far as osteoporosis, this is a very common problem. You should have a bone density if you're a woman and you're near menopause. If you have a problem, your physician doesn't think you need it, you should go through the websites and look at your individual risk factors, and you have to be an advocate for yourself. So if you really had an aunt who had osteoporosis and you just had a hip replacement, I'd be getting a bone density. And if your physician is reluctant, you've got to make advocate for yourself. All right, Deb, well, thanks a lot for having us here.
Thank you very much.
All righty. Take care.